Hello, I'm Dr. Leong. Today I shall be talking about managing shortness of breath or breathlessness. This talk is relevant to people suffering from chronic lung diseases like interstitial lung disease, COPD, chronic bronchial sepsis like in bronchiectasis, or those with chronic asthma. Disclosure, I have none. This talk is organized by my clinic, Leong Chest Clinic, and is sponsored by the Malaysian Thoracic Society and endorsed by the Perak Chest Society. This presentation is for public education only. It is not to be taken as professional medical advice. Please consult your own doctor for medical advice. Overview of this presentation. I shall be talking about interstitial lung disease, acute exacerbations due to infection, acute exacerbations from flare-up in the disease itself, disease progression, treatment, prevention of infection of the lung, pulmonary rehabilitation, oxygen requirement, pulmonary hypertension, equipment used in pulmonary rehab, lung transplantation, palliative care, and hospice care. Interstitial lung disease. Classification of interstitial lung disease. There are more than 100 types of interstitial lung disease. They can be classified into various categories or groups. Those with known causes or association, idiopathic interstitial pneumonia, granulomatosis, and others. In the known cause, you have systemic sclerosis. 88% of the people with systemic sclerosis have interstitial lung disease. And 64% of the patients suffering from rheumatoid arthritis have interstitial lung disease. Others include inflammatory myopathies, Sjogren's syndrome, SLE, mixed connective tissue disease, and vasculitis. The other common types of ILD is the idiopathic pulmonary fibrosis, which comes under the group known as the idiopathic interstitial pneumonia, and the granulomatous interstitial lung diseases like sarcoidosis and hypersensitivity pneumonitis. Depending on which country one is residing, sarcoidosis may be an important cause of interstitial lung disease. In other parts of the world, it may be idiopathic pulmonary fibrosis, hypersensitivity pneumonitis, or connective tissue diseases. How common is interstitial lung disease? In the US, it affects 1 out of 200 adults over the age of 65. There are about 50,000 new cases each year, and the number is likely to increase over time. In the US, 40,000 die from idiopathic pulmonary fibrosis each year. This is a survival graph showing sufferers with UIP, usual interstitial pneumonia, and those suffering from NSIP, non-specific interstitial pneumonia. As you can see, survival plotted over time, patients with UIP have a lesser years of survival than patients with NSIP. This is a diagram of a normal lung. Air enters through the mouth and enters the bronchi, and finally reaching the terminal bronchioles, where they reach the alveolar sacs. And this is the alveolar sac, and inside is the alveolar space where the air is. These areas marked in red are the capillaries, the blood vessels. And oxygen from the alveolar space will diffuse across this thin membrane known as the respiratory membrane into the red blood cells, where they are transported to various parts of the body. These are pictures taken through a microscope. Here on your left, you can see very many alveolar spaces, a blood vessel, and a terminal bronchiole. This is the normal lung. On the right, you can see a very distorted lung, fewer air spaces which are distorted, fewer blood vessels, thickened interstitial space with inflammatory cells, myofibroblasts, and collagen fibers. All these are stained pink and purplish in color. Here you have a cartoon showing a normal alveolus. Air comes into the alveolar space and oxygen diffuses across this thin interstitial space into the blood contained in the blood vessel. Here in pulmonary fibrosis, the air comes into the alveolus. Oxygen has great difficulty crossing the thickened interstitial space containing scar tissue. So the oxygen has difficulty crossing this interstitial space into the blood contained in the blood vessel. These are microscopic slides of the lung, showing a normal lung with multiple air spaces, blood vessel, terminal bronchial. Here is the abnormal lung in a person with idiopathic pulmonary fibrosis, showing a distorted lung, scar tissue, collagen tissue, thickened interstitium, fewer alveolar spaces, and fewer blood vessels. This is a slide of a patient with idiopathic pulmonary fibrosis. It shows honeycomb change. Here it shows distorted lung architecture, thickened interstitial spaces, layering of scar tissue, collagen scar tissue, and cystic spaces. When there are multiple of them, one layered on top of the other, they look on CT scan like honeycomb of a bee. This is a high-resolution scan of a person with idiopathic pulmonary fibrosis. Here you can see peripheral reticular shadowing, scarring, traction bronchiectasis, and subpleural cyst, one layered on top of the other, showing somewhat like a honeycomb of a bee. Here is a slide showing patients who do not have idiopathic pulmonary fibrosis. 1/4 of them have a progressive phenotype. The time from ILD diagnosis to the development of pulmonary fibrosis with progression is about 13 months. Here you can see in rheumatoid arthritis, systemic sclerosis, and other autoimmune diseases. Here is a slide showing the progression of fibrosis, which is really unpredictable. The reduction can be rapid, moderate, or slow. There's no way to predict the rate of severity or progression. Previous decline cannot predict future decline in patients with chronic fibrosing interstitial lung disease with a progressive phenotype. Some patients with pulmonary fibrosis may have a family history. Like in idiopathic pulmonary fibrosis, the incidence is about 25%. In fibrotic hypersensitivity pneumonitis, it is about 15%. In unclassifiable ILD, it is about 15%. Some genes linked to familial IPF or idiopathic pulmonary fibrosis are the MUC55B, TERT, TERC, etc. Symptoms and signs of interstitial lung disease. Some may be asymptomatic, and there may be a late diagnosis due to the insidious disease progression. And some may be accustomed to shortness of breath. So we really need to do some pulmonary function testing. Some may have chronic cough, which is persistent and dry. There may be shortness of breath during exercise, and the person may detect low oxygen saturation at rest or during activity. The person may also feel tired, and the doctor may hear crepitations or crackles in the lung, and there may be finger clubbing in patients with idiopathic pulmonary fibrosis. Some of the tests that are being done to find whether a person has interstitial lung disease include chest imaging, a plain chest X-ray, high-resolution CT of the chest, pulmonary function tests like spirometry, especially so the forced vital capacity or the FVC, diffusion capacity of the lung, the DLCO, the 6-minute walk test, echocardiography to detect right heart failure or pulmonary hypertension, viral test to find out whether a person has viral infection of the lungs, bacterial culture, whether it's bacterial infection of the lung, bronchoscopy may be required together with a bronchial alveolar lavage, and blood tests, especially in doing the autoimmune screen. and lung biopsy may be required for very difficult cases which cannot be classified. An accurate diagnosis of the type of interstitial lung disease is required. In idiopathic pulmonary fibrosis, there is no known cause, whereas in hypersensitivity pneumonitis, usually there is an inhalation of organic material. And in connective tissue disease, there is an autoimmune inflammation present. The behavior in idiopathic pulmonary fibrosis, the disease is usually progressive and has an unfavorable prognosis, whereas in hypersensitivity pneumonitis, the disease course is variable and it has a favorable prognosis, especially if the offending organic material is identified. And in connective tissue disease, the cause is variable and the prognosis is also favorable. Treatment in IPF is with antifibrotics. In hypersensitivity pneumonitis is the removal of the offending allergen and anti-inflammatory drugs. And in connective tissue diseases, the use of anti-inflammatory drugs like steroids and immunosuppressives. In idiopathic pulmonary fibrosis, the manifestations are in the lung, same as in hypersensitivity pneumonitis, whereas in connective tissue diseases, depending on the type, the skin may be involved, the joint may be involved, esophagus, blood vessels, or even the heart. We are going to do a case study now. Mr. X is a 60-year-old man who has been diagnosed with idiopathic pulmonary fibrosis. He develops a new cough, increased shortness of breath, nasal discharge, and fatigue. So the most important question is he getting worse? The question to ask would be, what are the alarming symptoms that he is experiencing? How to interpret the SpO2, the oxygen saturation, heart rate, and respiratory rate? Is there anything he should do at home? When should he seek medical advice? And when should he go to the emergency department? Acute exacerbations due to infection. Acute infection can be caused by the common cold. There are more than 200 viruses, and 30 to 35% of cases are caused by rhinoviruses. Others include adenoviruses, coronaviruses, human metapneumoviruses. The incubation period is usually 1 to 3 days after exposure. Transmission is by hand contact, droplets from sneezing or coughing. What are the cold symptoms? There can be nasal discharge, nasal obstruction, sneezing, dry or scratchy throat, cough which could dry, low-grade fever, tiredness, headache, and facial or ear pressure. The viral infection can extend downwards to the airways of the lung, and the symptoms will be cough, shortness of breath, and even wheezing. They may be preceded by the cold symptoms, and these are caused commonly by parainfluenza viruses, coronavirus, rhinoviruses, respiratory syncytial viruses, and the human metapneumoviruses. More serious will be the infection or viral infection affecting the lungs. There the patient may have fever, cough, and more pronounced shortness of breath. It's commonly caused by influenza or COVID-19. Common cold viruses can also be associated with pneumonia. Influenza or the flu can be seasonal. It is caused by the influenza A and B. The incubation period is about 1 to 4 days, on average 2 days. Viral shedding can occur 24 to 48 hours before illness onset. Transmission mainly through droplets, fomites, and may be airborne. Symptoms of influenza usually are more severe than that of the common cold. There may be fever, headache, muscle ache, tiredness or malaise, cough. Sore throat may be more pronounced. There may also be a nasal discharge, and it can be complicated with viral pneumonia or secondary bacterial infection. COVID-19 infection is caused by the SARS-CoV-2 virus. Incubation period is about 4 to 5 days, and transmission is via droplets. It can be airborne, and true fomites. COVID-19 symptoms can be pronounced. There may be cough in 50% of cases. There may be a fever, more than 38 Celsius, muscle ache, headache, difficulty in breathing, sore throat can be very severe, diarrhea, nausea and vomiting. There may also be a loss of taste or smell, abdominal cramps, and running nose or rhinorrhea. Pneumonia may be a complication leading to acute respiratory distress syndrome, which can be fatal. Bacterial pneumonia. These pneumonias are caused by bacteria. The symptoms could be cough, shortness of breath, fatigue, and fever. The common organisms in community-acquired pneumonia are strep pneumoniae, Haemophilus influenzae, Mycoplasma pneumoniae. And the patients who are predisposed include those over the age of 65, those with underlying lung disease, those with gastroesophageal reflux disease, and those who are on immunosuppressive drugs, and those who smoke. Acute exacerbations due to disease flare-up. IPF exacerbation. It is an acute worsening or development of breathlessness, usually within 1 month. It can be 1 or 2 weeks. The incidence of acute exacerbation in IPF ranges from 4 to 20% per annum. 50% die from acute exacerbation. Acute exacerbation in idiopathic pulmonary fibrosis has a poor prognosis with a median survival of 4 years. The exacerbation may be triggered by an infection, aspiration, medication, inhalational injury, or discontinuation of antifibrotic drugs or immunosuppressives. The CT scan shows bilateral ground glass opacities with or without consolidation, superimposed on a UIP pattern. CTD-ILD, connective tissue disease exacerbation. Respiratory deterioration accompanied by worsening imaging with new ground glass changes on CT. Acute exacerbation in CTD-ILD are less frequent and less severe than in idiopathic pulmonary fibrosis. Acute exacerbation of CTD-ILD has a significantly lower mortality rate compared with IPF patients. Here you see a patient with acute exacerbation of ILD. Air is black in color. As you can see in this, there is increase in ground glass opacity, more whitening. It looks like frosted glass as compared to this patient with existing interstitial lung disease, but you can see more black in both his lungs. Disease monitoring is important. We need to monitor disease progression. Different types of ILD behave differently. Some ILDs deteriorate faster than others. The stage of the disease when first diagnosed is also important. Patients with severe disease at diagnosis will have a shorter lifespan. The risk of exacerbation is also influenced by the presence of other comorbids. Some ILDs have a progressive fibrosis phenotype. Treatment options, new drugs, and affordability are also important factors to consider. After evaluating all the above factors, we will roughly know the outcome of the disease. How do we evaluate worsening? During exacerbations, the cough may worsen, being more frequent and persistent. At times, the dry cough can become productive with colored sputum indicating possible infection. Shortness of breath may worsen, requiring a higher flow of oxygen to maintain adequate blood oxygenation. Blood tests can be done to evaluate disease activity and sputum tests to detect infection. A decrease in FVC or forced vital capacity and a DLCO, diffusion capacity or carbon monoxide, will indicate worsening lung disease. So too is a decrease in the 6-minute walk distance. New appearances of ground glass opacities may indicate ongoing active disease. The detection of pulmonary hypertension may be the cause of worsening breathlessness. A check on the compliance to medication is also important. Because the medicine is expensive, some may choose to default. There are other causes of worsening breathlessness. With the onset of pulmonary hypertension, a person can become more breathless. The resulting right heart failure may need treatment. Heart failure may present with cough, leg swelling, and fatigue too. Pulmonary embolism due to deep vein thrombosis of the veins in the pelvis and legs are more common in patients with interstitial lung disease because of the decrease in physical activity and increased blood viscosity due to chronic oxygen lack. Pulmonary embolism presents with increasing shortness of breath, chest pain, cough, at times coughing out blood or hemoptysis, leg pain, and swelling. Cigarette smoking is also common amongst patients with interstitial lung disease. As such, the presence of COPD may be a contributing factor to the increase in shortness of breath. Treatment. Once the exacerbation trigger has been identified, one can give treatment. For virus infection, we can use antiviral, like in COVID infection, we can use Paxlovid and other medication. For bacterial infection, we can use antibiotics. For pulmonary embolism, we use anticoagulants. And for heart failure, we use diuretics and medication to optimize cardiac function. If a disease flare-up has been identified, we can either use steroids or immunosuppressives. Steroids include methylprednisolone, IV hydrocortisone, or oral prednisolone. And immunosuppressive drugs include azathioprine, mycophenolate, rituximab, and cyclophosphamide. When progressive pulmonary fibrosis has been identified, we use antifibrotics like nintedanib, Ofev, or pirfenidone. These medications reduce flare-ups and slow disease progression. How do we prevent infection in the lungs? The influenza vaccine is given once yearly. Antibodies developed within 2 weeks of injection. High priority groups include patients above age 65 and those with chronic lung disease, like in interstitial lung disease. Pneumococcal vaccination can help prevent strep pneumoniae infection, like in pneumonia, meningitis, otitis media, and sinusitis. The CDC recommendations include adults aged 19 to 64 years with chronic lung disease to vaccinate with PPV-23, and in adults aged above 65 years old, vaccinate with PPV-23 single dose and to consider PCV-13 if not previously received. COVID-19 vaccination is also required. Most of us have received our initial vaccinations and some of us may have received 1 or 2 booster doses. The upcoming bivalent COVID-19 vaccine has components which include the original strain of SARS-CoV-2 virus, the BA4, BA5 lineages of Omicron variant. Booster doses are still effective against the Omicron variant and the subvariant. High-risk patients should get second booster while waiting for the bivalent vaccine. There are also lifestyle modifications, like staying at home when sick, avoiding others who are sick, masking, hand washing, and practicing social distancing. One also required to optimize comorbidities like in diabetes mellitus and to stop smoking. Pulmonary rehabilitation program is also an essential. Principles of pulmonary rehabilitation. Pulmonary rehabilitation cannot make the lungs better. However, the exercises can make the body use the lungs more efficiently and tune the muscles so there is less demand on the lungs and heart. The results? Decrease in breathlessness, improved quality of life, and mood. Structure of the pulmonary rehabilitation program. It occurs 2 to 3 times per week. There is cardio and strength training exercises, education about the disease, and the exercises are performed in a safe environment. An exercise stress test to find whether there is heart problem is usually done before the commencement of the program. And nowadays, we have virtual pulmonary rehabilitation programs. In the program, one will be taught diaphragmatic breathing. Diaphragmatic breathing improves function of the diaphragm, improves oxygenation by enhancing airflow. Controlled breathing reduces respiratory rate. It is done with active inspiration using the diaphragm and passive relaxed expiration with pursed lift if there is a presence of COPD, in conjunction with proper body positioning. Pursed lift breathing reduces breathlessness and the respiratory rate. How it works is that it increases end expiratory pressure that prevents airway closure, especially in COPD, and improves alveolar ventilation. To improve chest mobility and flexibility, we have upper extremity and trunk exercises. They improve joint mobility and trunk flexibility, improves posture, and prevent muscle atrophy. There are some sitting positions that help reduce breathlessness. This is the forward lean sitting method. It improves diaphragmatic function, decreases use of accessory muscles of respiration, and reduces the respiratory effort. There is also this standing position which helps reduce breathlessness. The method is to have a forward lean standing position, as shown in the examples. The best sleeping position for patients with shortness of breath is to have their chest propped up. They can buy electric beds or chest supports to be put onto their beds. Postural drainage is to employ body positions to enhance clearance of secretion. There must be knowledge of the lung segment involved. It includes percussion, shaking, and vibration to loosen and mobilize the secretions. For patients who are severely breathless, the high side-lying position is employed. When there are secretions deep in the chest, we employ huffing to mobilize and loosen the secretions to the central airways so that coughing will be easier to expel the phlegm. There's less increase in intrathoracic pressure, thereby maintaining airway patency. To bring up phlegm, the controlled cough should be employed. It reduces fatigue, chest wall pain, dyspnea, and bronchospasm. It is used in conjunction with the sitting up or leaning forward position. The active cycle of breathing technique is a technique employed to bring up phlegm to be coughed out easier. It is a cycle comprising breathing control, deep breaths, breathing control, deep breaths, breathing control, and huffing to bring up the phlegm, and finally coughing to expel the phlegm. A person with lung disease like COPD will stop exercising on a cycle after a certain period of time. For the patient, the limiting symptoms at peak exercise are dyspnea or breathlessness and tired legs, and sometimes it can be both dyspnea and tired legs together. The vicious cycle of inactivity. When the person feels breathless, the person does less physical activities, and hence the fitness level decreases. The muscles weaken, and the person gets more breathless, and the whole vicious cycle goes on and on. The person doing less exercise, getting more weak, and the muscles will atrophy. What is exercise? Exercise is a planned physical activity. It should be scheduled. There should be overloads like the maximum heart rate or the maximum allowed breathless level. It should be specific. It could be endurance training, strength training, or flexibility training. Exercise prescription. There should be about 3 to 5 sessions per week, or most days of the week, allowing for sufficient rest periods. The intensity, it should be about the 4th to the 6th level on the modified Borg dyspnea scale, meaning the person should feel moderately severe breathlessness, or somewhat severe breathlessness, or even a little bit of feeling of severe breathlessness. It should be about 60 to 80% of the peak work capacity, and it should be done at a lower capacity at home, unsupervised. The duration of exercise should be about 20 to 60 minutes. It can either be continuous or be broken down as interval training, where there is intolerable symptoms. The exercises can be walking or cycling, and must include upper and lower limb exercises. Strength training should also be included. The program lasts for about 2 to 3 months. During exercise training, one must include warm-up, the main exercise, after which there must be a cool-down period. Exercise equipment can include the treadmill and reclining cycle. While using the treadmill, one has to be careful to prevent falls. The reclining cycle is best suited for the elderly, as there is back support and also support for the body. It will be less trauma to the joints as well. Upper limb exercises are very important because by exercising the upper limb muscles, which some of them are also accessory muscles for respiration, one can breathe better with them. Some of the accessory muscles of respiration are the pectoralis major and minor, the serratus anterior, the trapezius, and the latissimus dorsi. Bands can be used for resistance exercises. They can strengthen muscles. The 6 P's of energy management. Number 1, prioritize activities. Remove unnecessary activities. Perform activities which require most energy first. Number 2, plan schedule within limits. Schedule for days, weeks, or months in advance. Pace oneself. Slow down and divide tasks, like if the room is very large, do one section of the room first and sweep the other part of the room later. Take breaks and naps in between tasks. Energy management. Number 4, position the body properly. Push or slide objects instead of carrying them. Sit while working, like in the kitchen, preparing food. Sit while working instead of standing. And arrange the environment, like placing objects at heights easy to reach. Practice pursed lip breathing when doing activities requiring effort when the person is having COPD. Number 6, have a positive attitude, relaxed attitude, and reduce anxiety. Mental well-being is important. Think positively. Imagine being in a beautiful, scenic place, like having a holiday at the beach. Be humorous. Watch comedies instead of crime scenes. Practice prayer. Peoples of faith are usually more settled and know that there is life after death. Meditation may help. There is also medicine which relieves anxiety and depression. Have a healthy, balanced diet. Being overweight can overwork the lungs and make breathing more difficult. Being underweight can lead to weakening of the muscles involved in breathing. Keep up the energy level by eating adequately. By being well nourished, there's a feeling of well-being, and this also strengthens the immune system. Causes of malnutrition in patients with chronic lung disease. First, there's the airway inflammation, which uses energy and nutrients from the body. There may be altered metabolism from increased work of breathing, side effects of medication like steroids and beta agonists, and also gastrointestinal disturbances. There may be inadequate calorie intake due to a decreased appetite, early satiety, and nausea. While eating, a person with chronic lung disease may have shortness of breath and fatigue. Social isolation may be also a factor in bringing food to the table. Patients with lung disease can continue to have sexual activity, but must practice controlled breathing and coughing. Use a pillow to support the back. Use positions that require less energy. And do not put pressure onto the chest. And let the partner be more active. Sometimes useful for COPD patients to use the bronchodilator 20 to 30 minutes before sexual activity. Sleep disruptions occur with anxiety and stress. The cough may be particularly worse at night, and the shortness of breath may also be worse at night. Acute reflux causes heartburn during sleep. There may be altered sleep architecture, especially so with obstructive sleep apnea or OSA. Here the person snores at night, and during apneic spells, the oxygen saturation may actually decrease even further. Practice good sleep hygiene. An adult usually requires about 7 to 9 hours of sleep. That will be optimal. Have a good bedtime and wake-up schedule and maintain it. Exercise earlier in the day so that the person can fall asleep easier. Have strategic napping. Plan the naps at appropriate time. Avoid large meals, caffeine, nicotine, alcohol near bedtime. Stop smoking. Here is a graph showing the loss of lung function over time. For a sustained quitter, there is still a gradual loss of lung function. But as you can see, for a continuous smoker, the fall of lung function is even worse compared to a sustained quitter. Take time for leisure, like walking the dog has a calming effect on the person, and socialize. Have group activities, and this will elevate one's mood. Join a support group and provide mutual support for each other. There may be also supervised discussions with doctors and nurses. Group activities are enjoyable. Oxygen need. There is severe oxygen lack when the person's oxygen saturation measured with a pulse oximeter is less than 88%. For these people with severe oxygen lack, it is advised that they continue to have oxygen therapy for more than 15 hours per day. Effects of chronic oxygen lack, like in the brain, it causes cognitive impairment. In the heart, heart failure. The increase in respiratory rate causes a sensation of breathlessness. Vasodilation of the peripheral blood vessels cause an increase in heart rate. An increase in erythropoietin due to oxygen lack increases the blood viscosity, thereby causing possible blood clots in the legs, and therefore pulmonary embolism. And vasoconstriction and remodeling of the lung blood vessels causing pulmonary hypertension. An increase in lactic production in exercising muscles will reduce exercise capacity. However, shortness of breath can also be due to reduced lung compliance. That is because the lungs are stiff. It can also be because of ventilation-perfusion mismatch, whereby areas of the lung being ventilated is not perfused, and areas of the lung which is perfused is not well ventilated. And it can also be caused by cardiovascular dysfunction. Here is a survival graph of patients who need oxygen, meaning they have severe hypoxia at rest. And you can see patients who use oxygen for 15 hours per day survive better than those who do not take oxygen at all. It goes same for men and women. Oxygen supply. Here we have oxygen cylinders, portable oxygen concentrators, lightweight portable oxygen concentrator with a battery, and stationary oxygen concentrator, and this model has an adapter which can be used at home to refill oxygen tanks. Oxygen delivery. This is a nasal cannula. It can be as long as 25 feet. This nasal cannula has an optimizer. With an optimizer, the same amount of oxygen can be delivered at a lower flow rate. This will allow for a single oxygen tank refill to last longer. This is a humidifier. This is a face mask. It should not be used unless one can deliver oxygen at 6 liters per minute. The usual stationary oxygen concentrator at home will deliver 5 liters per minute. The air that we breathe in contains 21% oxygen. Oxygen delivered via a nasal cannula at a flow rate of 1 liter per minute will give an oxygen concentration of about 24%. When given at 5 liters per minute, the oxygen concentration is about 40%. This is a pulse oximeter. Accurate readings come from proper placement of the device on the finger. Read from the finger with the highest value. Check the waveform. Regular tall waves mean the device is sensing the pulse strongly. Besides the oxygen saturation, note the pulse rate as well. A doctor's prescription is required before giving oxygen. Giving too much or too little oxygen can both be harmful, as there is concern if giving too much oxygen, there is carbon dioxide narcosis. Be safe while using oxygen. Be careful while walking with long nasal cannulas. Do not trip and fall over. Do not have open flames, spark or smoke near oxygen tanks or concentrators. For patients on 24-hour oxygen, please have a full oxygen tank nearby in case there is a power outage when the oxygen concentrator will fail. Pulmonary hypertension. Incidence of pulmonary hypertension in interstitial lung disease. In idiopathic pulmonary fibrosis, 18 to 51% have pulmonary hypertension as confirmed by right heart catheterization. In idiopathic pulmonary fibrosis, at initial lung transplant evaluation, 38% have pulmonary hypertension. At time of transplant, 86% have pulmonary hypertension. For fibrotic hypersensitivity pneumonitis, pulmonary hypertension is present in 31 to 50% of cases. Pulmonary hypertension causes right heart strain. Pulmonary hypertension is defined as mean pulmonary arterial pressure of greater than 20 mm mercury. Here, the mean pulmonary artery pressure is 21 to 24, and you can see the right heart, which is still quite normal sized, and this is the left heart. At higher pulmonary pressures, the right heart becomes enlarged. The right ventricle and the right atrium are both enlarged in this case. At even higher pressures, the right heart will fail, as shown in this diagram. Some equipment used in pulmonary rehabilitation. Increased airflow over the face is known to lessen the sensation of breathlessness, while some facial nerve stimulation. This can be achieved with battery-powered electric handheld fans or simple hand-powered fans. Vibratory PEP devices or positive expiratory pressure devices are used to mobilize and prevent accumulation of secretions in the airways. They improve airway function and gas exchange. They also help prevent lung atelectasis. Incentive parameters increase respiratory muscle strength. They improve respiratory muscle endurance and exercise tolerance. Nebulizers can be used to administer bronchodilators or airway openers. They can also be used to administer saline, either normal or hypertonic saline, and also mucolytics. These are used to make the phlegm thinner so that they can be coughed out easier. High walking frames help by providing support to the upper body while walking. Breathing can be easier. The rollator has a seat which will be very handy when feeling exhausted. Lung transplant. Lung transplantation is a topic by itself. Here, just to mention that lung transplant is available for patients with COPD and idiopathic pulmonary fibrosis. Palliative and hospice care. Palliative care should be offered at the time of diagnosis of any serious illness and be an extra layer of support. It is focused on symptom management. The goals of care should be well spelled out. There is also place for advanced care planning. Advanced care planning focuses on making decisions about healthcare once, if one is unable to speak for oneself. Decisions are based on own preferences, values, and discussions with loved ones. This is particularly important when there is a respiratory crippled who has an acute illness and is unable to breathe. The decision then would be to ventilate or not to ventilate. Hospice care is for any person likely to have 6 months or less to live. Most people don't receive hospice care until the final weeks or even days of life. So in summary, there are many causes of interstitial lung disease. One needs to make an accurate diagnosis so as to know the prognosis. It's important to identify acute exacerbations and know when to seek help and when to get into the emergency department. Thank you.